Okay, good afternoon, everyone. And it's great to see that the p-value of the meeting has been good, and you guys have been attracted by the pizza and hopefully by the topics that we're going to be talking about today. I see a lot of familiar faces, folks who have come from all the way from China, so welcome, Brian. And I see a lot of stalwart supporters of the mHealth community here at Hopkins. We have members of the steering committee. For those who don't know, Ed Bunker has been leading a lot of the teaching initiatives here at the school around digital health, leading a flagship course on mHealth and eHealth at the institution. So my name is Alain Labrique. For those of you I haven't had the pleasure to meet yet, welcome. It's really been a privilege for me to lead what's known as the Global mHealth Initiative here at Hopkins, which really has been a consortium of projects and faculty and students working in the space that has graduated from eHealth to mHealth to now digital health, and so really encompassing a lot of innovation in both public health and clinical medicine, where untethered mobile telephony or handheld devices are used. So it's a very dynamic space, and as I said, for those of you who were here a few minutes ago, we're competing against job fair today. So there's a whole zoo of folks downstairs recruiting students. So there's a lot of folks who are busy downstairs securing their future careers. And we're also competing against the gentleman from Google who is talking about machine learning and AI. I'll say a few things about machine learning and AI so you guys don't feel too left out, but because that is the buzzword du jour. And it's hard to get away from whatever keywords get you funded these days. So we'll be sure to throw some of that in as well. So I like to start, and this is sort of the first lecture of the series. We're going to be doing a number of digital health lectures over the coming few months. And I just want to quickly introduce Jordan Downey here, who's our student leadership person, who's going to be helping to organize a lot of the guest speakers in the next few months. So if you're a student here and you're interested in digital health, come talk to Jordan afterwards and see how you can get involved. But I put this up because this is really my geek bona fides. And some of you have been to my office, you've seen the proud piece of my collection, which is this device, right? How many of you know what this is? Anyone? Yep, right? It's a tricorder. It's a medical tricorder. And for those of you who have seen sort of the original Star Trek, you would go up to your patient and scan them with this technology in the palm of your hand. And Gene Roddenberry, almost half a century ago, imagined this technology in the hands of the crew of the USS Enterprise, exploring space. And when you think about their vision was for the 23rd century, that we would have a technology that you could hold in the palm of your hand and look up information on demand. You could diagnose individuals, you could communicate over long distances with audio and video, and you could do vital signs, heart rate, etc., just from this piece of technology. And now I will venture to say that each of you in this room has that technology in your pockets, with the exception of maybe Ed. But I think Ed's upgraded, so you probably have one now. But when we think of fancy gizmos and technology, we're not limited to places like Baltimore or Seattle. The reach of the global mobile phone revolution has been wide. And so this is a picture I took a few months ago when I was visiting a small community in rural Kenya. And as we were walking through these homes, I realized that there was numbers scratched into the earth with which these buildings were constructed. And as I was inquiring whether this was some kind of malaria census number or some kind of local, spiritual number, it turns out, no, this is the mobile phone number for the individual who lives in this home. So mobile phones have started to become identification coordinates for individuals across places where even electricity hasn't yet made it. So I think some of you who've worked in areas like this can also attest to your personal experience that this is increasingly true.
You just violated it.
What's that?
Rule on data disclosure.
You can't do it. I've changed the numbers around, so you can't really see it. But let me show you this. So this is a picture I took in rural Gaibanda, where we work. And this is a micro SD card. Okay? It can hold now they sell them up to a gigabyte, almost a terabyte of information that can be held. It's a 128 gigabyte card. And across rural Bangladesh, you will find these being used to exchange bootleg copies of Hindi music videos. So the potential now to transfer large amounts of data on things such as micro SD cards is the reality that we have to struggle through and understand the potential for in global health. And just thinking about what you could hold in terms of libraries of information, video, audio, and textbooks, making this accessible to folks all around the world. So phones in public health and medicine. And I think it's not lost on any of you in this room why we're talking about this. When you look at this map shows the countries where mobile telephony has penetrated dramatically over the past 15 years. And you can see that the countries that seem to be inflated the most are the countries where those of us working in global health struggle to achieve high coverage with essential interventions that prevent maternal and newborn mortality. Sub-Saharan Africa, South Asia, these are the same countries where the opportunity is overlapping with the problems that we've been trying to solve. So as public health professionals, it's contingent on us to think about how do we leverage this new reality to try and attack some of the health systems challenges that we've been facing for many years. Now, 2G is sort of the norm in most of the world, which is a regular text messaging and voice communications. But 3G, 4G, and now 5G are starting to make inroads in places where we thought previously these would be unattainable using modern technology and networks. In fact, what's interesting to note, and we have a colleague who's working in Uganda, who often says that 5-6 years ago, when they were scouting out the area around Kampala to see if it would be feasible to transmit large packets of video information through rural Uganda, they noticed that despite the fact that the networks were only 2G at the time, the infrastructure was 4G ready. So the towers were capable of doing a lot more than what the networks themselves were prepared to do. So there's a lot of infrastructure that's available. In Bangladesh, the national backbone for mobile telephony is a fiber optic cable network that was laid alongside the railways years and years ago, but now is being used to split things. But at the highest levels of global health leadership, we are starting to see digital health really playing an important role. This is just from a few weeks ago. Tedros, the new DG of WHO, lists among the 3 reasons for optimism right up front. Digital health is one of or digital technologies is one of the big things which he's seeing on the future. So for us at the School of Public Health, it's really contingent to think about how we are leveraging these to solve problems. In fact, middle of last year, in May of 2018, there was a World Health Assembly resolution encouraging countries to think hard about how we use digital health to accelerate progress towards the now SDGs. And so I'll make these slides available on the website so you guys will be able to dig in further and actually look through some of these documents. Because these are the political tools that enable us to move either experimental practices forward or to test new ideas in places where we think they might be appropriate in low resource settings. In fact, one of the things I wanted to also mention, just day before yesterday in India, another declaration was issued by 32 member states of the United Nations for promoting digital health inclusion in health system strengthening strategies. But back in October of 2016, the WHO actually launched its first ever guidelines development group for digital health. And this was actually a very important landmark because it was moving digital health away from sort of the lunatic fringes of those of us who are trying new and exciting things to being a serious considered tool by WHO as one of the things alongside other strategies to solve global health challenges. And so the guidelines took 2 years, and I'm pleased to say that in the next 3 weeks, the guidelines are going to be officially issued by WHO, and I'll talk a little bit more about that in a minute. The guidelines actually tackle these key areas of importance in terms of digital health strategies that have been used in the world, and extensive literature reviews and evidence syntheses have been done by the Cochrane Group to look at the state of evidence across each of these different strategies. So electronic decision support, management of commodities, provider-to-provider communication, and so forth, looking at whether or not there's sufficient evidence and sufficient confidence across a body of experts gathered from around the globe to recommend this to implementing agencies as well as national governments. So this is currently on the verge of being launched, and you guys heard it first here, and it's coming very, very soon. Now, when you leave this room and you go and talk to people about, oh, I just went to a meeting about digital health or mHealth, they'll say, oh yeah, I'm doing mHealth too. And I think one of the big breakthroughs that has happened over the past 10 years is really increasing the nuance with which we speak about digital health, that it's not all one big conglomerate thing, that there are many different flavors or aspects to digital health that you can use this technology or these tools to solve problems using these various strategies. Now, this was the first attempt that some of us in the room worked together with WHO and UNICEF to put forth a taxonomy, a description of what are the ingredients to make a digital health soup. So a piece of work in China may choose to use digital tools for provider training and human resource management, but that's very different from a project in India using a digital tool for electronic decision support at the point of care. And this nuance is very important, guys, because what it does is make sure that we are not treating this as some kind of monolithic thing, that there's differences in what we're measuring as the outcome and what we're measuring as the intervention using these digital tools. Now, I'm pleased to say that that was almost 8 years ago, and as of 4 months ago, the WHO has actually released a much more updated version of this, and that's this classification of digital health interventions that aligns the international standards organizations, the International Telecommunications Union, WHO, UNICEF, and a whole host of other bodies working in this space. This is available online. I have a few paper copies if you really, really would like a paper copy. But what it does is it allows us to really clarify the way we speak about digital health innovation, so that as you're working with a Ministry of Health or as you're working with a donor agency, you can articulate very clearly what it is you're doing and not just broadly digital health writ large. So it's broken up into 4 different bins. We have interventions for clients, where the clients of public health services are the primary focus of the digital health. For providers, for resource managers, and for sort of data systems as a whole. And I think this binning of things allows us to think about which areas we're actually focusing when we're doing a health system strengthening intervention. So we recently did a comprehensive review, and a number of you in the room were part of this effort, where we brought together both Hopkins and non-Hopkins experts from around the world to look at the health system's building blocks and where we stand in regards to these different bins of digital health innovation. And this is available at the Global Health Science and Practice website for free, and you're welcome to go there and take a look at some of these really, really, I think, insightful articles, looking at each of these health system building blocks and where we stand in terms of digital health investments in these spaces. Now, the one thing I do want to stress, though, and this is something that also has emerged in addition to sort of refinement of language, is the idea of focusing ourselves on the problem and not the shiny object, right? And you'll see in a lot of the early days of digital health, there was a lot of excitement by vendors and companies that were building widgets to talk about, oh, this sensor saves neonatal lives, right? And what we find is the evidence was not only sorely lacking, but also the articulation of what specific health system challenge are you addressing with this wearable technology or with this tablet-based decision support tool. And so this taxonomy of problems is included in that classification to allow you to articulate not just the technology solution, but also the problem itself in a very careful way. Now, some of you may think, okay, this is very, very focused on low and middle income countries, but even here in East Baltimore, we share a lot of challenges for health system access that we would find in parts of rural South America or parts of Sub-Saharan Africa or South Asia in terms of remoteness, ruralness, difficulty to access, not just geographic, but also sociocultural access of health systems and health services. Resource-limited populations, we have them here as well as all around the world. Care coordination, losses to follow-up. One of the biggest drains on any health systems is a loss to follow-up once you get someone into care. And finally, communication. And with this last week's headlines of all of the investments that are being made by the anti-vax community, billboards going up all across Canada to promote non-vaccination of children. I don't know if all of you have seen all this, but there's been a concerted effort just in the past few months to ramp up anti-vax messaging. So the duty on all of our shoulders right now is to leverage tools like these to combat some of these anti-public health messaging. Now, there are two myths that I want to dispel very quickly, and that is, when we talk about phones, we often get the criticism that, oh, I've been to places where women don't own phones, or that the populations are so illiterate, how could they possibly use technology? Well, I'm sure those of you who have worked in rural communities around the world can back me up here, that ownership and literacy are not necessary barriers to using this technology. That members of the community, even going back to the early days of the Grameen Bank, one of the first initiatives that Professor Yunus, who won the Nobel Prize, had supported was giving mobile phones to rural women to sell phone calls as part of a micro enterprise. So these kinds of technologies are widely available either through community members who sell these services or through local pharmacies or tea shops that also sell phone calls by the minute. So a lot of this is not necessarily a barrier. So when we think about the major barriers to equity in health, all of these different things compound upon each other, whether it's social, economic conditions, environmental conditions, behaviors. And what we need to be thinking through is how mobile telephony, how access to cellular networks can improve access to information. And I'm looking at folks here who are working either in JPIGO or at CCP, the Center for Communications Programs, where a decade ago, information in many parts of the world was the privilege of the few, right? You had to be wealthy, you had to have access to a library or access to technology to allow you to access even the most basic information. And that's no longer true. It's a democratizing technology if used right. And we have a few caveats that I'll mention just at the end. But technology is being used for empowerment, for public reporting, social media, right? And I think some of you may roll your eyes immediately, like social media is evil. But actually, there's many instances of social media being used for good, to augment health system performance and demand creation for care. The other paradigm that I think is important for us to be thinking about is we have a lot of tools in our arsenal of public health. How many of you are here at the School of Public Health? Quite a few, I'd say a majority. And so you're familiar with these packages of essential interventions that over the years, as we've generated evidence of things that work, vaccines, skilled birth assistance, all of these different strategies can be used to reduce morbidity and mortality. But the challenge for us is taking those interventions to reach levels of effective coverage. We know BCG vaccine, we know oral rehydration solution. One of the most cost-effective interventions globally has yet to reach levels of 90, 100% coverage in populations which need that intervention the most. So how can we use digital technology to fill these potholes on the road to effective coverage? And so that's sort of the strategy that I will challenge all of you to be thinking about. In reaching that level of effective coverage, how can I take advantage of digital tools to fill some of these gaps? Now, we often get frustration from ministries of health, from large NGOs who are seeing all this activity in this space, but don't necessarily have the tools to make good decisions in terms of, do I go with this solution or do I go with that solution? Well, first of all, that's why we need more informaticians. A good nod to our friend here, Ed Bunker. Informaticians who are trained in being able to see through the glossy handout and actually look at the engine behind the tool and see whether, in fact, this is going to work at national scale, whether this is going to do the things that the vendor is promising it will do. But, you know, basically 3 questions. Is the solution solving or addressing the problem? And we've talked about the taxonomy of problems. Is it economically viable for this context? Because there are loads of solutions that are not at all economically viable. I'm not going to name them here, but there are many of them targeted specifically to low and middle income countries, only to find out 2-3 years down the road that they cannot sustain those investments because they continue to accrue costs. And then finally, is it scalable and replicable? One of the things I learned very early in this game is text messaging. Okay, text messaging.
Are you figuring it out?
It grows linearly in cost as you increase the number of individuals. There's no sort of, you can get small discounts at all, but at the end of the day, the more people you involve in your schemes, the more cost you're going to incur to send out those messages. So you have to figure out ways to make sure the cost can be sustained at scale. And so I think these are the 3 questions that, if you're going out there and helping people make decisions about these tools, you have to keep them at the top of your mind. So let's take a look at some of these solutions. And some of you have seen these examples before. I've thrown in some new ones. But across these 3 layers, let's look at what's being done. So at the patient level, this is one I'm really proud of because Hopkins faculty have worked very hard and close with the Ministry of Health of South Africa to transition what was once an experimental program called MAMA, Mobile Alliance for Maternal Action, which was sending pregnant women text messages during their pregnancy, is now a national program that every pregnant woman in South Africa has free access to. So during pregnancy, based on your gestational age, you'll get text messages reminding you to seek certain services or take up certain behaviors as an effort to increase your care-seeking behavior, but also your self-efficacy. Across India, the BBC Media Action, working with the national government, has been launching a number of initiatives to strengthen the capacity of frontline health workers. What you see here is what they call mobile kunji. And kunji are keys or reference cards, which a frontline health worker, when she goes to visit a family, can pull out this deck of cards that's beautifully color-coded according to stage of pregnancy or postpartum period with standardized counseling messages. Now, Some people are great at delivering counseling messages, other people are not. What this allows you to do is dial a phone number at the bottom of this card, and it reads out a nicely recorded, standardized message. So you can then focus on, do you have any questions about this, or can we talk about this, rather than delivering the content itself. The content is recorded with music and other things that make it more interesting and exciting to follow. And Hopkins is actually involved right now in doing an evaluation of this intervention. When we talked a little bit earlier about adherence, right? How many of you, when you're given a prescription, manage to take every single tablet exactly as you're supposed to, morning, noon, and night? Wow, everyone's so honest here. That's great. Or maybe you were about to raise your hand, so congratulations to you. But I certainly don't do that. And one of the key simple interventions that I honestly think, when you go to a CVS and pick up a prescription, your phone number should be in that system, and you should get text message reminders, because the evidence is extremely strong, repeatedly through randomized trials, that sending text message reminders improves adherence to appointments and reduces non-adherence to drug regimens. So this works very well in malaria, in HIV, in a whole host of different disease states, and is quite efficacious and really, really simple to send as an intervention. This was something that actually was born out of this institution, IMOCA. Directly observed therapy for the growing pandemic of tuberculosis. The amount of manpower required to send people, community health workers, out to the field to observe dots as it's being taken, versus being able to call someone up on a smartphone and watch them actually take the drug and hide it under their tongue. But you can actually reduce the burden and cost by implementing things like this. And now this has not only gone, I will say, viral around the globe, but across the United States. Health departments across the US are using these kinds of virtual dots therapy solutions to implement directly observed therapy. In some parts of the globe, fake drugs are a major problem. And groups like Sproxel and Pedigree are allowing pharmaceutical providers to tag their blister packs with key numbers that can be dialed in using your phone. And then you get a feedback message saying this is an authentic or not, based on
I wanted to upload tickets to Be More Chill.
at the central pharmacy.
I picked a date, 2 tickets, and now it says what type of ticket is interesting.
This is, old as the hills, right?
Global screen.
Technology, way back when we had personal digital assistants and Newtons. I don't know if folks remember some of these really ancient handheld devices. But the first use cases was to load up all of those clinical reference material onto these devices, and now you can hardly find a doc across the street, or even in hospitals in Kampala or Nairobi, who don't have access to Hippocrates or drug reference material on their devices.
There's a help here.
But now what we're also doing is task shifting. I'm working with a group in Bangladesh where they're empowering frontline pharmacists and folks who may not have had the competence or the level of professional training to do a basic screening of patients.
Check out our video.
Competent referral.
Any friends who want to take these?
But through this low-cost tablet system, you can have continuity of care with a patient, but also a video conference with a clinician who's based in a call center 500 miles away, and get a much better triage of that individual at the point of care. We all understand that a lot of disease and ill health stems from social determinants of health. And so we have a Hopkins team who's been working on providing digital tools to assess the social determinants of an individual who comes in, to understand what their needs are.
Let me call you back. I'm trying to listen to
morbidity with which they're presenting, to understand whether they need food stamps or housing assistance or other alleviation of the burdens that they're struggling with, in order to improve their actual health outcome. And so this tool has also been growing nationally here in the US as part of a digital repository. Now, many of you in the room may be familiar with this tool that Hopkins also has been a core partner in. It's a WHO piece of software that digitizes paper registers in order to allow frontline health workers around the world to more easily manage, and these are fake names and fake pictures, but more easily manage their clients across a large catchment area. And so we're actually involved in a large randomized controlled trial testing the efficacy of this in reducing neonatal and perinatal mortality. At the system level, one of the most painful parts of running a health system in a low-income setting is running out of essential materials. Whether it's running out of drugs or essential supplies, making sure that you reduce stockouts is a major goal in these contexts. One of the early trials that Novartis actually supported was this thing called SMS for Life, a very basic system that was provided to frontline pharmacists where they said, okay, here is how you will actually store your essential antimalarials in your shelf. First shelf is this, second shelf is this, third shelf is this. At the end of each day, you send us a text message with the count of the number of bottles on each shelf. That's it. Just count the number of bottles and send us a hashtag separated text message, 23, hashtag 12, hashtag 4. Immediately that gets processed by the central supply, who then send in a requisition for more bottles if the stock is running low. And what was astonishing is you start to see stockout levels drop, not just gradually, but plummet, because the information gap, not knowing what level your stocks were at, was the biggest gap in knowing when to resupply those essential drugs. Now, what was neat here is they built in a little bit of an incentive for the provider. If you reported your drug levels on time, you would get a small incentive like free airtime on your phone. So you could use that tool for your work to actually call your family, interact with other friends and relatives and so forth. But each day you were late, your reward got smaller and smaller. So really a lot of neat things that you can do in these kinds of things. BBC Media Action has also been working on training health workers. So using the phone as a way to communicate training material to workers around the globe. So this is one where the worker actually gets a certificate at the end of completing this kind of continuing medical education, but now at the level of the frontline health worker. This is one that actually Microsoft Research in India worked very closely with a number of NGOs to launch a program called Digital Green, which I just think was really innovative because it leverages the concept of the positive deed. Everyone familiar with that? So the concept of finding people in a community who are doing things right, who are doing things in such an exceptional way that we want to use them as the model for their own communities. And they would go and find, so this was actually used for agriculture, they would find a farmer who was doing a really good agricultural practice, and then members of the community would use readily available tools, small video cameras, micro projectors, to make a video of what that individual was doing, and then in the evening call a village meeting and watch a video together on the wall of a house to learn these new methods from their own peers. So another very interesting digital solution. And as we become more and more sophisticated, and I think this is where I will drop the machine learning and AI terms, using some of this digital data to extract intelligence, so how to optimize our programs, moving from maps that we use like this to manage our program distributions to maps where we can now in real time, as this data is coming in from frontline workers, we're able to now understand where there might be gaps in coverage, not 6 months after the program is over, but the very day that the program is elapsed, I can say, oh, look guys, we've missed a whole segment of this village area. We need another mop-up team to go in and clean up that space. And so the ability to monitor and course correct a program in real time is really, really exciting. Now, there's other groups that are also looking at ways of reducing some of the burden on the health system by employing artificial intelligence in ways that 5 years ago we would not have thought possible, right? So you're actually working in China. Melody chatbot is from Baidu, is one of these innovations that has actually made a lot of inroads, I think with a good amount of criticism, but the fact that you can task shift that initial set of questions to a natural sounding robot. Like now when you go to a website, you go to Amazon or you want to buy a new set of tires for your car or a widget for your lab, you get a little picture that pops up. Hi, I'm Sarah. Can I help you? 90% of the time, it's not Sarah. It's a software called Sarah who's asking you the 10 questions that would otherwise have placed an undue burden on a human being, but they can capture that information and then present it to the worker who can then expedite the amount of work that she has to do. So natural language, see like, how many of you fly United? Anyone call the United Airlines has a verbal chatbot that actually does this. Like, why is the computer going, Because, and so they purposely put in this sort of human, I'm thinking, when actually you could just go on to the next question, but it makes us feel more comfortable that we're interacting with maybe a human. So that's part of this. But for symptom checking, drug interactions, a lot of this can be, for the most part, automated and then task shifted when not possible. And you can see what they do is that they escalate if the chatbot's not able to answer the question, then they can escalate it to an actual human being. I think over the coming years that line between whether we're interacting with a chatbot or a human is going to become increasingly blurred. And for those of you who haven't seen the video yet of the Google Google Talk, I think it's just 5-6 months ago they released an interaction where the Google AI engine actually called up a Chinese restaurant and made a reservation for 6 people on the next Wednesday, with the Chinese restaurant never realizing that it was a computer that was doing this on behalf of the individual. So we're really getting into some shady territory. We're actually working right now with the government of Bangladesh to develop strategies to use AI in a way that the private sector has been using AI for over a decade, right? UPS trucks, FedEx trucks, the United States Postal Service, a lot of these different groups that are doing spatial movement use optimization algorithms to figure out in real time what's the best route to take to deliver packages. If a new package joins the bunch, it'll reclassify its plan for the day and give you a route optimization that reduces the amount of effort. And we're trying to do this with health workers in a rural community to see whether we can move from the paradigm of catchment areas to a paradigm where there are tasks, using an AI engine to manage those tasks and optimize them. And so stay tuned, because a year from now, we'll be able to tell you how well or miserably that worked. The other sort of boundary digital health technology that's emergent is drones. And this time last year, I gave a lecture on drones, and it was like, sort of futuristic. I had a drone fly from the classroom, and everyone was like, ah. But now there are thousands of drone corridors that have been set up across sub-Saharan Africa, across South Asia. The government of Rwanda has invested in a national drone delivery program for blood supplies and other emergency medications. Malawi now has a drone corridor that UNICEF is running. So this is quickly, I mean, within 12 months, moving from science fiction to science fact. The capacity of drones, the distance they can fly, the battery life, the reliability and safety of these devices is increasing day by day. There was a great report put out on the use of drones for humanitarian emergencies, and conferences are now all over the US. And the nice thing is it bridges the the gap between the virtual environment on your phones and the physical environment of getting supplies and medications out to rural communities. And so you can imagine a frontline health worker with their mobile phone out here diagnosing Ed Bunker with a certain, snake bite, and then as I push the button, it orders the antivenom to be flown in right there at the point of care.
Excellent.
There's a group in, not that I want you to be bitten by a snake, but there's a group in Baltimore at Hopkins testing whether, what are those things called? The emergency paddles for resuscitation? The IE, no, not IE, that's improvised explosive. Collective loss of defibrillators. The defibrillators to be sent to the point where someone is having an infarction to be able to start the heart before the ambulance gets there, as well as for drug overdoses. So so this is very real, and I would say, for those of you who are still looking at emerging areas, this is something to look at. So here's the thing that none of us can remember.
AED.
AED, the AED drone, right there. So this is one that one of our leading cardiologists, Eric Topol, is a big fan of. It's so exciting that this technology called AliveCore, which I remember many of us had, we got about 100 of them from the company to test here at Hopkins. It's an FDA-approved 2-lead EKG to do basically look at atrial fibrillation. And this is now, for those of you who have a 3rd generation or 4th generation Apple iWatch. Does anyone have a new Apple iWatch that does heart rate? It has built in the AliveCore. So you can touch the silver part of your watch strap, and then there's another part under the watch, and it basically does a 2-lead EKG right there on your Apple phone. So it's gone from this technology, and I'll tell you, I actually was diagnosed with tachycardia based on this very technology, because at these different conferences, I would pull this out and I would pass it around to everyone, and when it would come back to me, I would look at my heart rate and be like, wait a minute, why is my heart rate 3 times, 30 points higher than everyone else? And it turns out I have to, do some of this circumnavigational paddles. So mobile microscopy is rapidly becoming something that's exciting in many parts of the world, where you have to do rapid thin films. And again, this is where AI and machine learning built into the device or on the cloud can expedite the reading of these thin films, classify whether or not they see malarial parasites or hematological anomalies. This is one area where AI machine learning is very powerful in terms of visual pattern recognition, and potentially one that will vastly reduce the burden on humans, but also enable us to task shift more things to those populations. Ultrasound, and then again, there are good things and bad things with the ability to do ultrasound on your mobile phone, but the potential is really great to be able to do this. And even if you need to do a CD4 count, imagine doing that on the palm of your hand, rather than sending something to a lab and waiting weeks and weeks for that result to come back. This is from just a few years ago. A colleague at NIH shared this with me, that they're developing this technology. But I think most exciting also is where mobile health crosses over into these other sectors, like mobile money. Anybody work in Kenya or Tanzania or traveled there recently? Yeah? So have you had experience with M-Pesa?
I've seen it work, I haven't used it.
So about 70% of financial transactions in Kenya, day-to-day transactions, are done using M-Pesa, not with cash. You can just walk to a fish vendor, he hands you a fish, you type his phone number in your phone, and bam, he's got paid for the thing you just bought. Yeah?
Even formal, like electricity companies now, like I have to pay for my electrical bill with it.
There you go. So I mean, imagine now, you leave your ANC visit as a pregnant woman in Peru, right? as you leave the clinic, you get a phone call from the MOH saying, we see that you've just finished your visit. Could you answer 3 questions? Based on those 3 questions, the provider gets a bonus or doesn't get a bonus based on the quality of care or the consistency of care. But now you're getting feedback directly from the patient. I mean, these are some really exciting potentials for us to be thinking about. You know, they introduced not M-Pesa, but M-Paisa in Afghanistan several years ago as a means to pay frontline health workers. And the workers actually thought they were getting a 20% salary raise, because what was happening when we were moving packets of money around, the top note was getting pocketed each time the packet would move from one place to the other. And when you finally got your packet, it was a bit thinner than it was supposed to be. But when you transact it electronically, that takes care of that problem. So I think, you know, to think about closing out, you know, the case for investment, because without being too cynical, one of the things that we all sort of find out sooner or later in global health is that, you know, the money is at the heart of many of these issues, right? What does it cost? And what does it cost in terms of the problem? And what does it cost in terms of investment in a solution? Because very often the more powerful ministry is not the Ministry of Health, it's the Ministry of Finance who decides the budget allocations. And so this is the important part of the entire calculus, is thinking of what's the investment case, right? Are we improving or reducing leakage in the stock system? Are we having fewer losses to follow up, and therefore the cure rates are going up and we're losing less productivity? And are we seeing program operations being more efficient? You know, when it comes down to simple things like paper registers for frontline health workers, very often the immediate gut reaction is to say, well, a tablet is so much more expensive than pieces of paper. But that's not true. When you start to multiply the number of the amount of paper in a volume, the amount of time that it takes to print those ledgers, and the amount of time that's wasted by health workers in adding up columns and creating summary reports. And Jennifer here actually did her master's thesis on analyzing the burden that it takes a health worker to summarize this data on a weekly basis. And you're losing, you know, dozens of full-time equivalents of workers at a district level just in the time that's wasted adding numbers together and making arithmetic calculations when they could be actually providing care. Now, I won't say this is all roses and you know, diamonds, because I think there's real challenges that we have to face. And I think our responsibility as Hopkins has always been to be very pragmatic and make sure we're not, you know, selling things that are shiny objects. We have to understand that we're working with pluralistic health systems, many different kinds of providers, some of whom will be connected, others who will not be. We have to understand that there are many poorly implemented projects that can often give this space a very bad name. But I want to spend a few minutes talking about, you know, one of our fearless leaders' favorite words, and that is fake news, because I think it is contingent upon us to talk about. And you know, right now across India, there's actually a lot of initiatives that are being undertaken to quell some of these rumors that are being first spread through social media, WhatsApp, Twitter, and other things. Many of them are health related. So one of these recently was a misinformation campaign through WhatsApp around the danger of vaccines causing infertility and deformity, right? And this was an example of the video that was widely spread through WhatsApp on people's cell phones. And you know, they made the headlines in many different ways. WhatsApp rumors, and you can imagine with measles outbreaks, rubella outbreaks, it's a really terrifying thing. And you can see how this is growing exponentially. This is just in the past few years, we're up to 600 million users of WhatsApp in a country of 1 billion, right? So there's actually classes that are now being taught at the elementary and primary school levels to educate young people on how to spot fake news, how to be more resilient to the onslaught of misinformation. And you know, I'd be happy if someone can explain to me what is the driving advantage to this agenda. You know, what is to be benefited from anti-vaxxers and from people spreading health misinformation, other than just causing chaos? And I just, for the life of me, I can't figure it out. But I think these initiatives should not be just in India. Wherever you guys come from around the world, when you go back to work in the countries that you're connected to, how do you spread this kind of anti-misinformation campaign in those communities? You can see, like, I love this here. Here's a whole paragraph on clickbait and how to recognize clickbait. We have a lot to do still in terms of improving socioeconomic discrepancies, in terms of penetration and affordability, and I think a lot of the major telcos are working hard to do this. How do we improve technological literacy? Because we want people to be comfortable with using this technology so that they're not left behind by different programs that are designed. And I'll say this is one thing, like, as a school of public health, we don't have a class that's taught here on design and design thinking. Has anyone taken a course on that? Because I'll tell you, it's an essential part of communicating and designing programs. And we have MICA, not too far from here, the Maryland Institute College of Art, where they do a lot of design thinking, and I'm happy to see an increasing number of collaborations between MICA and School of Public Health. But you know, the University of Maryland did a survey last year of glucometers. You know, the off-the-shelf devices to check glucose levels for people with diabetes. And they found the top 25 glucometers off the shelf. And who is using glucometers most likely? Right? The largest demographic. You're talking about elderly individuals, people who may have other comorbidities, you know, rheumatism, limited vision, challenges to manipulate small devices. And the average glucometer looks like this, right? Tiny button, even tinier screen, cryptic messages, you know, and the instruction manuals that were just atrocious. And yet, you know, you would think this basic concept, you're designing something for 65-year-old individuals with rheumatic arthritis. What are you thinking? You know, don't design this. Design something more user-friendly. So the same thing applies with mobile phones and mobile phone interfaces as we think about that. I'm going to say a few words about gender, and I think this is one of the last things to really think about is just let these statistics sort of flow over you for a minute, because you can see that around the world, this is a major challenge for us to really break through. In patriarchal communities, the control of information, whether it was traditionally conveyed or whether it's conveyed through digital, is still controlled. And I think we have to figure out ways to break through and overcome these social and gender norms that are preventing folks. And it's not everywhere, though. We can see that the gender gap varies dramatically. In the Middle East and Northern Africa, it's only 8%. Europe, 4%. Sub-Saharan Africa, only 13%. Right? Latin America, 5%. When you start getting into South Asia, we're talking a much larger gap. And so you know, something that remains for us to think about and target. But this is heartening to see that across these global samples, you look at women who have never had the opportunity to try a mobile phone, and this is just from a few years ago, but yet the willingness is there. So you have a much higher sort of proportion of individuals who are willing to try if given the chance. And actually, this is, I think, a few colleagues from Mexico. This was interesting, where women report harassment from strangers as the greatest barrier. And you can see here that both men and women report in sort of these countries. In some countries, there's a big discrepancy, but women and men reporting an active harassment through mobile phones that they find enough to prevent them from using this technology. And then, you know, a whole host of other things, you know, network quality, handset costs. So these are still real barriers to phone ownership. Finally, I just want to say that all of these technologies don't exist in a vacuum. I think we have to understand that the fertility of the soil is an important part of growing these technologies. And we're increasingly over the past several years in addressing the info system. So those issues that you saw here, cost of the handset, the network coverage, et cetera, these are issues that are being addressed at a global level to make sure that the infrastructure is there to facilitate these technologies. And this is the Global Digital Health Index. Those of you who are interested in understanding where we are on a global stage, this is a really exciting tool that's just been launched and that looks at these various building blocks of the info system that enables technology. But there's also the Digital Health Atlas. And this is something that we helped launch with WHO, but it's a catalog at a country level of technology projects that are currently in deployment. And it's something that if you guys are working on a digital health technology, go to the Digital Health Atlas, check to see if your project is actually there, and if it's not there, upload it and make the database more reflective of current operations. And so for those of you who are representing different large groups within Hopkins, please make sure that your DePigo projects are reflected in this. Your CCP projects, your other Bill and Melinda Gates Pop Center projects are all reflected in the Atlas. And so with that, I want to say, it's been an exciting journey. And for those of you who are interested in digital health, come and talk to us. I know there's a few of you who are students of mine, and we've been working together. But there's a lot of cool stuff happening. Just because things aren't perfect doesn't mean we shouldn't do them. And this is a quote from Voltaire that says, "Le mieux est l'ennemi du bien," which means perfection is often good. And so we often get pushed back to say, well, there's a lot of problems, so we shouldn't quite do this yet. I will beg to disagree, because we've done already a lot of exciting things, despite the fact that we still have miles to go. And with that, I want to thank you guys, and I look forward to interacting with you guys. Thanks so much. And there's more pizza, and we have time for questions. And if you haven't met people in the room, please.
Wondering why you are confident in this
So it's a very good question. And the universe of what this represents, and actually I'll let you have this copy, because I think this answers that very question. Because what we recognize is the M part of the system is only one piece of the solution. That very often the mobile phone and the technology that's running on the phone is connected to other systems, maybe back-end national information systems, maybe cloud computing systems. So it's by saying it's just mobile tends to restrict it to just being something that you run only on the phone. Whereas what we're talking about is a universe of solutions where this is an essential part of it, but it's not limited to just the mobile technology. And so digital has actually been a very unifying term, because it helps bridge the gaps between people who are saying, who would traditionally say, well, I don't do digital health, I do telemedicine. Or I don't do mHealth, I do telemedicine. Telemedicine has mobile applications in it, so let's just back up, because there's no point in siloing each other in a space where there's so much to learn from each other's successes and failures. So it's really been a unifying term that we found over the past years. And with WHO moving towards digital health as a unifying term, it's put me in a bind, because my center is called the Global mHealth Initiative. So we're going to have to refactor things and maybe think about a Hopkins digital health initiative. But,
Is there any relationship between GHU or
Not really, not really. I think the key here is being untethered, right? I think it's the question of are you chained to a physical location, or can you take this technology to the point of care? Can you move with this technology? And so, as I said, a phone call is in some cases an amazing use case of digital health, where a family can call for an emergency support worker to come to the home. In some cases, that can make the difference between survival and death in a community. I think ICDRB, I was working with a team from Stanford who were using just phone calls where people who had children experiencing diarrheal episodes could phone a pharmacy to bring ORS to the home, right? That was it. It was just a phone call to a pharmacy to bring ORS to the child who was having diarrhea. And I think that's a fantastic, simple use case that is digital health, but that also solves the problem of not having ORS when you need it in the middle of the night, in a rural community. So,
you mentioned a few geospatial projects. I was just curious if you could elaborate a bit more. Are these projects that the center or some of the school is working on, and are they more mapping oriented, or is there also kind of an analytical component?
So the one that I shared for workforce optimization, that's happening here at the school. It's with a collaboration with a group called ONA and Johnson & Johnson. And so what that is, it's the mapping exists. That's already been done. It's sort of leveraging that GIS base map to see whether we can create these optimization algorithms for care delivery, as opposed to Amazon Prime delivery, right? So so come and talk to me if you're interested, and we're actually looking for people to work on that project, and Jordan actually is leading that initiative. So yeah, I'm happy to. What's your name?
Anton.
Anton. Okay.
The tachycardia that you had, was it only when you were about to give a talk, or was it?
No, it was unfortunately, one of the side effects of being a faculty here is you go to a lot of meetings and you eat a lot of calories, and your belt gets tighter, and I think your clothes shrink. So I think the shrinking of my clothes led to increased blood pressure, and so I think that's part of the solution. So yeah, I think it's a good treadmill or go to conferences.
Well, thank you very much for a very nice presentation. You mentioned bronzes are, very nice technology. What is it called 3D printers? And the idea of creating very rapidly. I mean, right now the scale is not there, but you can create tissues, you can do a lot of stuff, and then.
Yeah.
I don't know if you have thought of that, but that's one question. The second question is, it seems to me from the presentation that a lot of things experience our bottom. So you made a lot of emphasis in the audit show, approving, evaluating. And it seems to me that technology happened in the world in a decentralized way. Smart people get together, solve the problem, information network. Information, and then people implement. Why centralized approach and how is so key rather than trying to decentralize innovation and the trial and error that is typically in the moment.
So let me actually show you answer to your first question. So for those of you who are familiar with this Gartner hype cycle, and everybody who knows about this, so the Gartner Consulting Group puts this out every year, and it's actually a really fascinating technology cycle where you have the innovation trigger, so the new technology, you have the peak of inflated expectations, right, where the technology is going to solve all the world's problems, and then the trough of disillusionment, right, when you realize, no, it's not. But then some of the things lie in this graveyard forever and never make it out of this trough. But some things go up the slope of enlightenment into productivity, right? So very often, we either find ourselves working in this area or sifting through the debris that's in this graveyard to see, is there stuff that's where the shininess of the object has worn off, but where it's really worth us taking a second look to see whether there's a way for us to actually use this technology to solve a real problem. I think part of the optics may seem like it's not bottom up, but in fact the selection of which strategies we will use comes from observation of what seems to be working in the wild, right? So in the very beginning, I showed some slides of people using M-Pesa or people using the micro SD card, right? As we observe, and so my sort of recommendation to a lot of my students is to say first, observe digital health as happening in the wild, and take from that the lessons that what has organically emerged in that community as solutions to the problem, and then can we codify those organic ground up solutions to create a more formal program, to actually leverage it. So I think it's partly the optics that it seems like it's coming from the top, but even if you look at the stockout management system for malaria, right? The pharmacists reporting their stock levels on a daily basis. The inspiration comes from the fact that before that program existed, pharmacists were calling each other and calling central stock to say, hey, I'm running out of supply, we need to plan ahead. And so as phones make their way into communities, people start to solve problems using those phones, and then the programs sit back and observe and say, wait a minute, this actually is something that everyone should be doing. And so it's sort of learning from those examples. As far as 3D printers go, I think 3D printers, where is it on this map? Blockchain. I love that the blockchain is way up on the peak of inflated expectations, right? So if those of you who bought Bitcoin, like myself, but I think 3D printing, I think last time I saw it was somewhere over here. So there's, people are still trying to figure out.
Could you say something
I think that the question is, like for prosthetics, that's one use case where I've really seen some exciting potentials, right? Maybe I think because that printing tissues is required. You need a special substrate. You need the ingredients. You need sterile conditions. So I think the use case that we're seeing right now is people printing like in war-torn countries or places where prosthetics are expensive. You can actually model and then print a prosthetic pretty rapidly. And but it's something definitely to keep an eye on.
Where do you see avatar technology there? Doing RCT viscosity.
Oh, you mean the AI chatbots? I think chatbots are still up here now. So a lot of the machine learning is way up there. But so what's happening? When you have a new technology, there's so much enthusiasm. So everyone is trying to apply that to solve problems. There will be a rapid realization that 70% of the things that we were trying to do with this new shiny object aren't going to work, and then you end up with the 20% that actually did work, slowly making their way back up to mainstream application. Yep.
So along those lines, I liked how your graphic of filling in the potholes to implementation, to actually letting some of those things take hold, I think relates to what you were describing in terms of what will end up plateauing and being productive. I wonder for how long it takes for some of these to become effective. Do you think that the actual improvement of the technology itself, in terms of, so in the States we have phones that are constantly get the newest phone, get the newest
Yeah.
and our systems and our networks are changing, so we're getting 4G, 5G
Right.
moving forward. So once these are implemented in places that are more remote,
Yeah.
if it takes this long to implement, are we then just going to have a technology turnover as well? And how do you think that there's friction?
So one really exciting thing that's happened over the past 2 years is a lot of, so there's been a lot of frustration where governments have just, you know, I'll give you the example of Uganda about 5-6 years ago, where they were so fed up with the number of disconnected digital initiatives that were happening in their country, they just said, the Minister of Health said, stop. Fed up with you guys coming in here, doing your little projects and then running off and leaving this half-baked system in place. So he said, now from this point forward, if you're doing a digital health activity, come to the Ministry of Health, register the project, we'll make sure you're standards-based, we'll make sure you're doing something that we care about and not just playing around, and then we'll move forward, right? So that led to a lot of global conversations across donors. So just in November of last year, there was a donor alignment meeting in Berlin where we had, you know, all of the major donors from the Norwegian government to the UK government to USAID, Bill and Melinda Gates Foundation. They all came together and signed a declaration of donor alignment around digital investments, where they said we're pledging to not invest in the same thing over and over again. And so that's where the atlas comes in, where, you know, you're going to actually tell an applicant, go check the atlas, tell me that show me how your project is not something that's already being done somewhere else. And if it is being done somewhere else, what makes your thing different or special? But the other investment that was made is in this initiative called Digital Square. So like you think of a place where you can go and find what's called common goods? Global goods. So investments in the building block technologies that don't have to be reinvented each time. So an engine that allows you to send text messages, right? 100 vendors can come and tell you, oh, I've got an engine it's here in the global goods square. It's been purchased, it's been made available for free for governments and large, you know, implementing NGOs. So thank you very much, but we're going to use the global goods version because that's been sort of standardized and approved. So there's a lot of stuff that's now being put into the courtyard of the global goods initiative to prevent all of this reinvention from happening over and over again. I think the other thing that you know, when we're talking about global health applications of digital tools, there are very few large-scale examples where we're using 5G, 4G, you know, imaging with a sonograph and lasers, and no, it's very, right now we're solving basic problems, right? Do you know there's a stock out or not? Do you know there's a baby born or not, right? These are very, very relatively simple information gaps that are being resolved, or communication gaps that are being resolved using these technologies. So I think that those will be fairly robust to changes in the technology that's around them.
I get that when I was talking to you about the bottom down, what I was trying to say is that the market approach, which is I want the people in this pharmacy to solve the problems for how to be good. And there are ways some people will be trying to be good for them, and then that's how you sustain. So the market approach is what we want to see in this innovation, right? So if whatever problem we solve is welfare gain, and that should go back to the owner of the capital in those countries. Yeah. So where do you see that equation to this?
It's interesting because, you know, there's a lot of global health programs that are not, that fall more under the social responsibilities of the government as opposed to a sophisticated commercial or private sector set of activities, right? I mean, you still
we
have
right? I could have a very good company who sent this message. I work, but I could send it to the world. I could make a lot of money. Yeah. That's how we grow up, right? Yeah. What is what you don't like to work?
I'm not an economist, so that I'll ask you to come back to me. But for the large part, it's been more. Well, what we've seen is more partnerships where the ministry will either retain the services of a private company to do certain activities on their behalf, or we'll purchase wholesale, like this UNICEF 2 years ago. They purchased, they actually bought a company, they spent $1.5 million. They bought a company that allows anyone in this room, you could set up a text messaging system using a technology called Rapid Pro. Because UNICEF went out and bought the license, bought the software, and said, it's free and available for anybody to use. So that's the model. It's not been like, oh, if you want to do this, we've negotiated a discounted rate, so this company is happy, et cetera. They just bought the company outright and are going from there. So, yeah, I'm not sure. Right now, it's more, government investing heavily in either doing the technology or subsidized through grants and those funding. All right. Well, we've hit the half hour. I want to thank you guys so much, and grab a brochure and feel free to email me, and we'll stay in touch. And grab some pizza on your way out. I don't want you to do that myself.
Much then. So quickly. Location is
We'll stop.
private.